Hello, everyone. So welcome to this video / workshop that is being done for educational purposes on targeted neonatal echocardiography and neonatal echocardiography. This workshop specifically will be addressed for the parasternal short axis view that we can do in the context of a neonatal echocardiography. And really these information capsules are done for educational purposes. I'm Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and a lot of my research work involves using neonatal echocardiography to better assess cardiac function, as well as pulmonary pressures in the context of various neonatal conditions. If you have an interest, please take a look at some of the different projects and work that we're doing at the NeoCardio Lab. I am situated at the Montreal Children's Hospital in Montreal, Canada, and you will find a lot of the information we'll be talking about today on the website of the neocardiolab.com. So at www.neocardiolab.com. So we will go on with our module today on parasternal short axis. So this can be found on the NeoCardio Lab website under TnECHO, normal neonatal echocardiography, and in the parasternal short axis view. So when looking at the parasternal short axis view, you are cutting the heart basically at the base level and eventually going down up to the apex. And you're able to derive a lot of great information. So if we start with the first view here, this is a view where you can see that the RV outflow tract is your anterior chest. And in the back of your chest, you can see here actually your left atrium. We can also see some degree of the interatrial septum. We can see the right atrium. We can see the aortic valve that looks a bit like this peace sign. And I think here you can appreciate the three cusps of the aortic valve, and you can appreciate that it's not a perfect circular structure, but rather more of what looks like an in-between a triangular and circular structure. So we will be talking today about some of the anatomical information as well as some of the functional information that we can obtain from the parasternal short axis view. If we see here, our aortic valve is placed centrally, and you can see that this is your pulmonary valve that we can see occasionally during the cardiac cycle in this particular view. And so of interest, the right side of the patient is here, the left side of the patient is here, and in the normal anatomical configuration, the pulmonary valve is anterior and to the left of the aortic valve. So it's a bit like the right ventricle is wrapping around your left ventricle, with the outflow tract coming very anteriorly and to the left side of your aortic valve, which is in the normal configuration placed centrally. So you can use this view also in order to do an M mode. We saw in the parasternal long axis module that you can use M mode to derive what we call the LA on aorta ratio. So here you can see that the line of interrogation is going perfectly through the middle of the aortic valve and the middle of your left atrium. And so there is some literature to use this ratio as a way to quantify the degree of left atrial dilation, especially in the context of a lesion like the ductus arteriosus, which can lead to an increased pulmonary blood flow from the left to right shunting and the excessive QPQS. Now, just a caveat, remember that a lot of newborns will also have some degree of interatrial shunt because their PFO might still be present. And because of that, some patients will unload the left atrium into the right atrium through a left-right shunt and the interatrial area. And so the degree of left atrial dilation will be dependent on the obvious amount of flow through the ductus arteriosus, leading to excessive pulmonary blood flow and eventually to excessive pulmonary venous return. But it is also dependent on if there is a pop-off valve, so such as the PFO, which would unload your left atrium, as well as the capacitance or the diastolic function of your left ventricle and how easily it is to empty the left atrium inside the left ventricle. So here you can see that you can do the measurement at the time of closure of the aortic valve. And then you can either measure here at the beginning of the closure. So the closure occurs from here to the tip of the valve closure here. And the two ways of measuring the aortic diameter have been reported with great consistency for the ratio. And this is the ratio of the left atrium at the peak of the filling of the left atrium, which typically the left atrium will be the most filled when the ventricles are actually emptying. And so the ratio of the left atrium to aorta will give you a sense of the degree of LA dilation. Now, beware that if you have a small aorta, this ratio may also be increased. And so you may also have an increased ratio if you have a context of coarctation or hypoplastic arch, leading to a falsely increased LA on aorta. Falsely, I mean, it's still increased, but it's increased not necessarily because you have a large ductus causing excessive left to right shunting. So this is a nice view where we used our compression of images to try to see the left coronary artery as it branches out from your aortic area. And so your aortic valve usually will be connected to coronary arteries, and it's very important. In many of the actual anatomical studies done by our colleagues in cardiology, a great focus of attention is placed on having a better sense of what's happening with your coronary arteries. And so if you're seeing a patient in the newborn period with some degree of LV dysfunction, it's always something you also want to make sure is within normal limit, is your coronary arteries and the branching of your coronary arteries, both for the RCA and LCA, knowing that LCA and RCA will feed differently your ventricles and also different there's differences amongst the population also. So here we also used a very low speed calibration in order to see the red filling of the coronary, of the left coronary, in the context of the diastolic filling of your left coronary system. As you can see, you have a lot of the bleeding of the Doppler color, but you can still quite nicely see this red flow through the left coronary artery. And this is because the left coronary arteries are being filled during the diastolic phase of the cardiac cycle, but also the velocity of flow is typically very low. And so you have to use a filter that takes this into account whenever you're trying to see the flow through the coronary artery. And then there are some echo labs that will also Doppler the coronary blood flow to make sure that this is not just an artifact and it's actually the flow occurs during diastole in a positive velocity fashion. And this is another example of the flow through the left coronary artery with a very low Nyquist. So this is a clip outlining the implantation of the RCA, the right coronary artery, into the right coronary artery, the right coronary cusp area of the aortic valve. And so it's important to really see the actual artery and its implantation inside the area of the aorta, because you may have some pericardial folds that looks like a coronary artery and it's not a coronary artery. And then if you're lucky, you might also see the blood flow in the RCA, but it's more difficult because you are aligned in a way that in the parasternal short axis, it's much more difficult to obtain color flow into your RCA. The view of the parasternal short axis, if you are bringing your probe a bit cranial and to the left part of the chest in normal configuration of anatomy, you might see this kind of mustache, which is basically your right pulmonary artery and your left pulmonary artery. And this is a good view to measure the caliber of your RPA and LPA, especially as you know, newborns will have a tendency to have an abrupt curvature of their pulmonary artery, which can give you this flow murmur that we call peripheral pulmonary stenosis murmur, which is physiological. But what you want to do is outline in 2D the caliber of your pulmonary artery and eventually place color on them, and potentially even do a Doppler, pulse wave Doppler, to ensure that there's no increased velocity or stenosis. So again, we can see here that you can see the pulmonary valve and you can see your RPA and your LPA quite nicely delineated. And then here we've applied color to see the blood flow at a relatively high Nyquist, which is expected in the context of pulmonary blood flow, to see your RPA and LPA being filled with no acceleration or turbulence of flow within the caliber of these arteries. This is an example of another patient where we can see an actual small, tiny patent ductus arteriosus, which is red. And it's red because it's coming back towards the probe, which here you have your descending aorta and your pulmonary artery, which indicates that this PDA is left to right. So coming from the descending aorta towards the probe, which means towards the pulmonary artery. We will be speaking about specifically the ductus arteriosus in a specific module regarding that. And this is another view where you can do a sweep to outline that there's this very small closing ductus, which looks very restrictive, and you have your descending aorta here, you have your MPA, and so obviously you have some red flow coming from your descending aorta towards your main pulmonary artery. So going down into a sweep, it's always good to do a sweep from the base of your left ventricle towards the tip of your apex to really ensure that there's no regional wall anomalies in contraction. It also gives you a sense of the entire anatomy of your LV and of the septum. And although you would probably want to put some color after that on the septal wall to ensure that there's no interventricular communications, it's a good way to ensure that there's no big VSD. And already on sweeping, I can kind of see that there's a small area here, where I would suspect that there might be a small muscular VSD. So when doing this sweep, what you want to make sure is that you're oriented in a way that you will have your RV in the interior portion of your image, and that you have your LV that is outlined posteriorly. As you can see, as we sweep, we can see the two leaflet of the mitral valve that looks like a fish mouth. And then you can see the two papillary muscles that are attaching to your free wall. So the two papillary muscles are attaching to your free wall. And you can even see here your moderator band, which will characterize your right ventricle. And as you know, the morphology of the left and the right ventricle are very different. These two ventricles are interrelated. They're basically like a couple dancing together. So if one falls, the other one may fall too. And typically, the right ventricle is a much more trabeculated ventricle. It has a moderator bend, and some of the attachments of the tricuspid valve are coming into the septal wall, compared to the LV, which will never have septal attachment of the mitral valve and will have a relatively smoother surface. If you don't have a smooth surface of your left ventricle, you start wondering if there's a pathological process, such as either that you're having an inversion of your ventricles, or that you're in a situation where you have non-compaction cardiomyopathy or other types of cardiomyopathies. So already a sweep is a good way to have a good sense of the relationship between the different segments of your heart, as well as the contractional properties of your entire left ventricle, the contraction and the filling. So we talk about the sweep, looking initially at the fish mouth and then eventually coming to your apex. It's important to have the most, when you're obtaining this view, the idea is that you don't want to cut the ventricles in an angle that gives you a perception of a flat septum. So when you look at the interaction between the RV and the LV, the septal curvature will give you a sense of the pressures on both sides of this wall. And obviously, looking at the phase of systole and diastole will give you completely different information. Typically, if you have either an increase in the RV afterload or a decrease in LV afterload, and or together an increase in RV afterload and decrease in LV afterload, you'll start seeing the appearance of septal flattening during systole. Why systole? It's because your RV will equalize with the pressure in the main pulmonary artery when the pulmonary valve is open, which is at the peak of systole, and the LV will equalize with the pressure in the aorta at the peak of systole when the aortic valve is open. And this is obviously true. The assumption that the septal wall gives you information about the afterload pressures is true if you have normal configuration of your RV outflow tract, if you don't have stenosis, and also if you don't have a massive VSD that will cause equalization of pressure during the cardiac cycle between the two sides of the septal wall. So if we start at the base of our ventricle, we can see this fish mouth, which outlines the two leaflets of the mitral valve. You can even put your color box in this view to try to see if you have sense that there's a mitral regurgitation or leakage. It's a good view to see the relationship between your RV and your LV. And typically at the base of the ventricles, the contraction is not as pronounced because there is the fibrous insertion of the valves. And so typically when we will be looking at the contraction, you want to be slightly at the tip of the valve in order to be able to obtain also your M mode. And we've outlined some of the information regarding the M mode for the shortening fraction in the module on parasternal long axis. So this is the view where you would be looking at your RV and your LV in terms of your septal wall. So you can see here your papillary muscles, and you can see that the right ventricle will take this crescentic configuration when the RV afterload is below the LV afterload. And so you want to appreciate this at the peak of systole. Flattening of the septum or bowing of the septum at the peak of systole could be indicative that you have increased RV afterload or that you're in a situation of LV hypotension or a combination of both. So you always have to put these images in the context of the clinical picture of your patient. So one way to measure the septal flattening is what we call the eccentricity index. So at the peak of systole, when your LV is completely contracted, you can do the measurement that is parallel to the septum and divided by the measurement perpendicular to the septum. And if you have a perfect circle, this ratio should be close to 1.0. You can also use this view to quantify the degree of RV dilation relative to the degree of the LV cavity diameter. And so you can do the D3 on D2 ratio. And if your ratio is increasing, it's because your RV is either dilating or your LV is very small. And we see that with, certain degree of RV hypertension, you get eventually a pancaking of your left ventricle. And so eccentricity index, depending on which ratio you're doing, the D1 on D2 or the D2 on D1, and both have been described in the literature, will give you a sense of how much septal flattening there is in these patients. So that's an example where this group described a population of premature patients that were followed for pulmonary hypertension. And they found that by measuring the eccentricity index as the septum was flattening, your ratio of this measurement divided by this measurement was increasing, which makes sense because this will start becoming more and more squished by your right ventricle. And an eccentricity index that was above 1.3 was associated with markers of impaired RV function. So that's an example of at the end of systole. So you can see the QRS, there is contraction, and at the peak of systole, you can see that this patient has a very round left ventricle and a relatively nice, thin, crescentic right ventricle, while this patient with some degree of pulmonary hypertension has an RV cavity that is quite dilated and actually more dilated so than your left ventricular cavity, which looks like this D-shaped. And you can see again that you have a much more important parallel value compared to perpendicular value. So obviously there's, here it says normal less than 1.23 because we are doing this value divided by this value. And so you wanna take this into account. Yeah, sorry, no, it's the inverse. So we're doing this value on this value, which normal would be closer to 1, which means that you're closer to a circle. Another example of eccentricity index. So these are examples of progressive septal flattening. So you can see how this patient has a very round septum throughout his cardiac cycle, while this patient has almost a bowing of the septum inside the LV cavity at the peak of systole, but also has flattening and diastole. And this patient has actually completely pancake the left ventricle and almost obliterate the cavity during systole. And so patients who have progressive systolic dysfunction of their right ventricle and increased afterload will eventually have an impact on the capacity to empty the ventricle, and will end up with increased right ventricular and diastolic pressure, which might end up causing some septal flattening even in diastole. Typically, we would see isolated septal flattening and diastole in patients who have long-standing left to right shunting via the ASD, causing a lot of loading, preload increase in the right ventricle. So you can also do a pulse wave Doppler of your RV outflow tract in the parasternal short axis view. So we have seen the concept of doing a PW or a pulse wave Doppler in the main pulmonary artery at the tip of the pulmonary valve in order to assess the velocity time integral. You can also measure something called the the pulmonary arterial acceleration time to RV ejection time, which has been a measure that has been associated with increased RV afterload. So typically newborns with very low pulmonary vascular resistances or low pulmonary RV outflow tract afterload will have this very U-shape appearance of their velocity Doppler because there is no obstruction of flow, while patients with increased PVR will have a tendency to have more of this triangular type of profile, Doppler profile. So one way to quantify this, the PAT on RVET ratio, is to actually look at the time spent during the RV ejection phase, which is the entire Doppler here and curve, as a way to normalize for heart rate, because these babies have fast heart rate, and to look at what we call it the pulmonary acceleration time. So you have here time and velocity. So this is the entire time that you spent with forward flow in your pulmonary artery as the pulmonary valve opens. So obviously the entire time is considered to be the ejection time. And the time that you spend accelerating gives you a sense of the degree of increased afterload. So if you have this U-shaped appearance, you'll have a tendency to have a more prolonged acceleration phase. And so here you can see that the PAT on RV ejection time, the PAT is 85 milliseconds. So this is time here. And the ejection time is 224 milliseconds. And so the ratio gives you 0.38. This patient, though, has a much shorter ejection time. So you can see that the ejection time is only 21 millisecond, and that, sorry, the acceleration time is 21 millisecond, and the ejection time is 271 milliseconds. And so as afterload increases, you would have decrease in this ratio. So in this context, 20 divided by 271 would be a ratio of 0.08, and a normal ratio would be considered 0.3. So anything below 0.3 would be considered abnormal. So this is an example of a patient who has a very nice parabolic smooth Doppler profile. And this is a patient that you can see that the acceleration phase is very tiny. This is just the demonstration that some patients will also have what we call a mid-systolic notch. And the reason for this mid-systolic notch is because there might be some degree of recoil of the actual pulmonary artery, in the sense that if you have a lot of obstruction to flow, such as in the context of high PVR, eventually you get ejection inside your pulmonary artery, which has a certain capacitance from the pulmonary wall, and then you get some recoil. So you get initially an acceleration, a deceleration, and a reacceleration from the recoil of this pulmonary vessel. This is an example of applying the velocity time integral to be able to assess the stroke distance. So here we're measuring that this PRBC during that time set can travel 19.4 centimeters. This is another example of a pulmonary insufficiency jet that you could obtain in the context of the parasternal short axis view. So you can see here that we have put our line of interrogation through the pulmonary valve, and that you're able to get a tracing with your peak of diastole and your end diastolic, which gives you some degree of estimation for either your diastolic or mean pulmonary arterial pressure. So these are a nice example where this patient, for example, has a peak of 30 and a mean, an end diastolic estimate of 16. And this one has a peak of 33 and an end diastolic of 18. So this was the review, short review in the parasternal short axis view. There's many other things that can be looked in the parasternal short axis. You can scan the septum using color. You can also try to obtain your tricuspid regurgitant jet from this view, as well as from the parasternal long axis by looking specifically at the tricuspid valve. And typically from this view, you can start noticing a patent ductus arteriosus if present. We will address some of these concepts in the upcoming modules. So I hope this was useful. And then please, if you have any comments or if you have any suggestions, you can go on my website on the Contact Us and then send me an email. And then if there's modules that you have in mind that you would like us to address, it would be our pleasure to design them. So thank you for your attention.